So this is supposed to be state-of-the-art percutaneous mitral valve therapy. So I'm going to talk to you about some of the similar things as Norman Messin and in fact Nick. Okay, so these are our learning objectives. We're going to review the prevalence of mitral valve disease, discuss the challenges associated with transcatheter therapy, review what's currently available in terms of technology for mitral repair, and then discuss briefly at the end the emerging transcatheter mitral valve technologies. So mitral valve disease, what is the actual problem? And Norman Messin touched on this earlier this afternoon, but if we look at the disease burden of valve disease, this comes from the EuroHeart survey. It was actually published in the Canadian Journal of Cardiology in 2014. What you see very clearly is how prevalent mitral regurgitation actually is. And in fact, that prevalence does increase with age. So when you're looking at the 55 to 64 age group, again, mitral regurgitation dominates the other valvular disease, but as our patients get older, mitral regurgitation is becoming an increasing problem. If we look at the different regions of Europe, regardless of where you look, you start to see that mitral regurgitation is almost equaling aortic stenosis in terms of prevalence of disease burden in these areas. And this is another North American study that looked at prevalence in New York State of either moderate or severe mitral regurgitation. And in fact, in the over age 70 population, it's approaching approximately 10%, and it is more prevalent than aortic valve disease, in particular aortic stenosis. So we know that mitral regurgitation is now divided into two etiologies, primary or secondary, degenerative or functional. And the therapy used for those, it varies, and the results vary as well. So when we look particularly at secondary MR, we talk about this unmet need. So if we look at patients, obviously we've seen here from the surgical live in a box cases, and we've heard from our discussions with surgeons, that surgery really is a good option for patients, particularly degenerative mitral regurgitation. The problem occurs in those patients who actually aren't getting any access to treatment. And then that's where the unmet need comes in. And patients, why are they denied surgical intervention, tends to fall into one of these four boxes. They're elderly, they have congestive heart failure, diabetes in this study, or significant comorbidity. And what you can see here is as the ejection fraction decreases, more and more patients the decision is to not operate. And again, as patients get older, the decision again falls more to not to operate. This is a more recent look at data from the Cleveland Clinic. And in fact, if we look at patients with mitral regurgitation by etiology, so either degenerative or functional, you can see that the majority of patients with functional MR, almost half of them are in fact the decision is made for medical therapy, so they're denied surgical therapy. And if you look at what the outcome of those patients are, at 5 years, only 90% of patients have been hospitalized for heart failure, and 50% of those patients are actually dead. So they're denied surgery because of their functional MR, and that functional MR really does impart a poorer prognosis. So this is another study that looked from the Duke data bank. And again, you're basically seeing the same sort of thing. Patients with FMR are more likely to be conservatively treated. In this group, you can see it's a very small percentage of patients that are actually undergoing isolated mitral valve surgery. And what is the impact of leaving these patients with secondary MR? We used to think that if you had heart failure and MR, your real problem was your LV disease. It probably still is, but the fact that you have MR in association with your LV disease certainly does affect your mortality. And in fact, severe MR is related to a worse prognosis in terms of survival and a worse prognosis in terms of recurrent hospitalizations for heart failure. And that's regardless of the etiology of your heart failure, be it ischemic or non-ischemic. So what's the challenge of mitral valve disease, particularly from a percutaneous perspective? So this is really the mitral valve anatomy. It's very complex, as Nick has already described. I won't belabor the point, but it really is a mitral valve complex, not just the valve leaflets itself, like the aortic. We need to take into consideration the ventricle, the chordae, the left atrium, and the mitral valve leaflets as well. And so if we talk about potential approaches or potential targets for a percutaneous approach, we can target all of these things, the mitral valve leaflets, we can target the annulus, we can look at chordal implants, we can even talk about remodeling the left ventricle, or at the very bottom there, we can talk about mitral valve replacement. So Nick has already showed some beautiful pictures of mitral valve anatomy, and this is just to show you, in particular, all I wanted to talk about was the proximity of that mitral valve to the LVOT, as Nick beautifully described. This is an important consideration, particularly when we're talking about mitral valve replacement. So what are the challenges? If we're talking about repair, ideally what we want from a percutaneous repair is something that's safe and durable, that's going to reliably reduce mitral regurgitation. We would like it to be applicable to both primary and secondary MR, and we want the procedural success to be high. When we talk about replacement, we want to obviously minimize LVOT obstruction, paravalvular regurgitation, and in a perfect world, we want a device that's easy to deliver and a procedure that has less morbidity than a traditional surgical procedure, and obviously availability of different sizes to treat a variety of patients. So what are the potential solutions? I'll talk to you first about transcatheter mitral repair and where we are. So as we mentioned, targets leaflets, annulus, chordal apparatus, and left ventricle. So if we talk about the leaflets, the currently available device is the MitraClip to target mitral valve leaflet repair, and it does emulate the Alfieri edge-to-edge repair. There have been over 30,000 implants worldwide, so worldwide, this is the device with the most experience. In terms of clinical trials, they probably are surpassing most in terms of clinical trials, but to remember, the majority of these patients are not being treated in clinical trials, but more in registries. So this is what the system looks like. You've all seen it. What types of patients have been studied? So if we look at patients in the Everest, we've studied patients with significant mitral regurgitation. In terms of the Everest trial, they had to have EFs greater than 25, ventricles that were not too dilated, a jet that came from A2P2, a valve area greater than 4, and there are some issues here with flail width and gap, and an FMR in terms of a coaptation length. Everest 2, that you're all aware, was a randomized trial of surgical candidates in primarily degenerative MR, and the primary endpoint was a composite endpoint looking at freedom from reoperation, death, and major complications. And the conclusion of the study in 2011 was that it was less effective at reducing MR, but it was superior in terms of safety and improvement in clinical outcomes. So we're 5 years out now from Everest 2, and this data was presented by Ted Feldman. And what you see here that's very interesting is you see a division in terms of degenerative mitral regurgitation and functional mitral regurgitation. And you see the results in terms of surgery and MitraClip, and this is event-free survival, event being reoperation or death. And as you can see here, the curves are somewhat similar. The big separation of the curves occurs early on, and that's when patients were reoperated early on because of residual MR. After that, you see the curves are relatively parallel in terms of surgery or MitraClip. And at 5 years, you can see in the degenerative group, freedom from event-free survival, 89% for the clip, 85% for surgery, and significantly lower, obviously, in FMR, 59% and 55% at 5 years. If we look back at all the data that we've amassed on this particular technology, this was a systematic review published spanning from 2000 to 2013, 111 publications. I won't go through this in detail, just to show you that this population that we looked at in the systematic review was actually patients who were older, who had lower EFs than what you saw in the Everest trial. You see that again, the STS score was relatively high, so these are higher risk patients than what we saw in Everest, again, older. And in terms of procedural success, you'd see that over the past few years, this procedural success has improved significantly. The worst procedural success is actually the Whitlow paper, which is the early Everest experience. So now you're looking at procedural success anywhere from 85 to 100%. In terms of results, so if we look at death, stroke, bleeding, prolonged ventilation, ICU, or hospital days, you do see in over 6,000 patients a significant benefit. This is a systematic review. However, you do see a significant benefit in the percutaneous approach versus surgery in these high-risk patients. If you look specifically at just FMR, and this was a meta-analysis published earlier last year, you can see that MitraClip If you look at patients in follow-up, treatment with MitraClip was associated with improvement in 6-minute walk, marginal improvement in injection fraction, but we do see some reduction in end-diastolic volume, end-systolic volume, pulmonary hypertension, and reduction in left atrial volume. But you do see what we know about these patients with FMR, that the death is still something that's important in these patients. All-cause death at 6 months at 9% and 17% at 12 months. So this gets back to the underlying illness of these patients. This will hopefully be answered by the COAP trial, which is a randomized trial looking at MitraClip versus medical therapy, optimal medical therapy, the primary endpoint of which is hospitalization for heart failure. 424 patients enrolled, and now there is FDA approval to increase enrollment to over 500 patients. So we're hoping to have those results in the next few years. So if we move on from the leaflet repair and talk about annuloplasty, so targeting the annulus in particular, we have 3 devices actually that have CE mark that Nico previously showed us. And so perhaps it's interesting to just go back a bit and look at all the devices that haven't quite made the cut. So if we talk about coronary sinus annuloplasty, the only device that's still, that has CE mark is the Carillon, the cardiac dimensions. And you can see these other versions that have been stopped, the Monarch, the Viacor, and the St. Jude Medical. If we look at direct annuloplasty, we have 2 devices that are CE marked, again, the Cardioband and the Mitral line. 3 of those have been stopped. That was radiofrequency ablation to the annulus, and there's some other devices that are going into patients, and hopefully we'll have some data soon. So why did so many of these annuloplasty techniques actually fail? Initially, what we saw was low efficacy, not an inability to reduce mitral regurgitation, some concerns about compression of the circumflex artery resulting in myocardial infarction, and then other complications like what was seen in the Viacor of erosion out of the coronary sinus. So these techniques have shown some promise. Currently, there are 3 approved, but a lot of those that fell by the wayside. So this is the Carillon. I'll talk a little bit about this. This is the device that's inserted into the coronary sinus and performs a coronary annuloplasty. It is adjustable, recapturable, and you can evaluate the MR in real time. You also have to evaluate any effects on the circumflex artery with this device. They have multiple multi-center clinical studies right now. So there's Amadeus, Titan, and Titan 2, so we'll talk a little bit about those. So Titan and Titan 2. So Titan was a comparison of patients that were implanted versus those who they were unable to implant. And basically what you can see, these are patients with predominantly functional MR with low EF and dilated ventricles. And in those who were able to successfully have a device implanted, you do see a change in the mitral annular diameter. So in green are those patients who had a successful device implantation versus those in blue in which the procedure was unsuccessful. You see an 11% reduction at 12 months in mitral annular diameter, so septolateral dimension, and a 27% reduction in the mitral annular area. This was also associated with a decrease in the regurgitant volume and as well as a decrease in the vena contracta. So in those people who had a successful procedure, there seemed to be improvements in both regurgitant volume, vena contracta, and the dimensions of the mitral annulus. The results appear to be durable if we look out to 12 months. That's the extent of the data that we do have. We do see that these results appear to be durable in those who had a successful procedure. And we see an improvement in both 6-minute walk and NYHA class for those patients who had a successful procedure. In terms of adverse events, the device implantation appears to be safe. We're looking at 1.9 to 2.8%. It's difficult to understand in those patients who had an unsuccessful procedure why that was unsuccessful. What are the anatomical variants, perhaps, that make a patient unsuccessful for this particular approach? And so right now there is a randomized clinical trial underway in the European Union and Australia called REDUCE FMR, looking particularly at FMR patients. And the control group will be medically managed, and they'll be randomized 3-to-1 to device or medical therapy. The primary endpoint here is going to be change in regurgitant volume as opposed to a clinical primary endpoint, and the secondary endpoints will be hospitalization and major adverse events. So they're looking at 120 patients at up to 20 centers. I'm not sure this is already enrolling, but this device, we should have some more data in the months to come or in the years to come. So if we go back now to the Cardioband, this as well has CE mark as of last year, and this is a percutaneous mitral annuloplasty as well. This is a device that's implanted by transeptal access and basically screws in an incomplete annuloplasty into the mitral annulus and fixates it with little screws into the mitral annulus. The advantage perhaps of this technique over perhaps a leaflet technique is this doesn't preclude the option of putting in a mitral valve replacement later on, as probably is the case with a MitraClip, for example. And as you can see here on these 3D echo images, this percutaneous mitral annuloplasty looks quite similar to a surgical ring. So there has been some data that's been presented, and I have these slides from Francesco Maizano. So 45 patients, age 71. Again, what you see here is low EF, so predominantly functional MR, ischemic, non-ischemic, slightly more ischemic than non-ischemic. Euroscore 2 of 7, and the majority of patients were symptomatic. So if we look at the safety at 30 days, we do see 2 patients who died at 30 days, one with a hemorrhagic stroke, one who needed a mitral valve operation. Bleeding complications were low. 2 patients did have renal failure. The early procedures of this were quite long, requiring up to 6 to 8 hours to perform, which gave patients a lot of radiation as well. Was associated, however, with a reduction in the anterior-posterior dimensions by echo, and was associated with a 20% reduction on average of anterior-posterior dimensions. If we look at mitral regurgitation in this cohort, what you can see at discharge now, we see the majority of patients with 0 or 2+ MR. That result seems to be stable out to 1 month, 6 months, and 1 year. So that's only 17 patients at 1 year follow-up, but 94% of those patients had an MR less than 2+ at 1 year. We also see functional improvement in terms of Minnesota Living with Heart Failure, 6-minute walk, and NYHA class. And in terms of effectiveness, in terms of early outcomes at 6 months, 87% with MR less than 2+ at 6 months, and 95% with MR less than 2+ at 12 months. So I'm just going to bring this up. So we've talked a little bit, I'm not going to talk about mitral line, but we did talk about the annuloplasty approaches for mitral regurgitation. I found this interesting, and I thought I would show this to you. This is use of a transcatheter sapien valve in patients who have severe mitral annular calcification. And there have been multiple case reports published, and now there's actually data from a registry of patients who have severe MAC that are being treated with an Edwards sapien in the mitral position. And this is, in fact, the TMVR MAC Global Registry. These are slides from Maya Guerrero from Evanston in Illinois. And they have 64 patients with from 32 centers in 11 countries that have looked at using an Edwards sapien valve. I believe Nick is on this list. He's done a case as well in patients with severe MAC and seeing those results. And so if you look at this, these patients were older, they were symptomatic, they had diabetes, they had previous CABG in about a third, and their STS score was relatively high. We're looking at 14% predicted risk of mortality. Baseline echo characteristics, preserved LV function, mean mitral valve gradients of 11, with a mitral valve area of 1.08. So the predominant pathology here is mitral stenosis as opposed to mitral regurgitation, pulmonary hypertension, a small LVOT gradient. Some patients had MR, but the majority of these patients actually had mitral stenosis. So these were the valves that were used. So Sapien, Sapien XT, Sapien 3, Innovair, that must be in Europe. And these are the different sizes that were used for this valve in MAC. And these are the different delivery approaches. So transatrial, transapical, transeptal, and something they're describing as a modified transeptal in order to place this in the mitral annular calcification. Oops. So these are the procedural outcomes. So technical success here by the MVARC criteria was 73%. Need for a second valve, either due to migration or significant mitral regurgitation, was 15%. And LVOT obstruction was 7.8%. So 5 cases ended up with LVOT obstruction with hemodynamic compromise. 4 patients had valve embolization, and there were 4 patients that had to be converted to open surgery, 2 LV perforations, and 1 pulmonary vein perforation. If we look at the 30-day procedural mortality, 12.5% mortality at 30 days. In those who died, LVOT obstruction and 2 LV perforation and 2 heart block. And then there were 17% of patients that ended up with non-cardiac causes of death, likely related to their existing comorbidities. So this is an interesting procedure, but I think the results are very sobering when we look at the mortality at 30 days. Relatively high if we think about TAVI mortality now between 3 and 5%. We're looking at 12.5% mortality for this procedure. So certainly not a procedure that has without concerns. In terms of technical success, 62% in the first half of the experience that rose to 84%. And again, you see the mortality. 30-day mortality, 37% here for the first half of those patients treated, went down to 22% in the second half, but certainly not insignificant, and certainly issues with LVOT obstruction and valve embolization. Mean mitral valve gradients were quite good. We see a reduction in those who had a successful procedure. But I think the important thing is this is out there. People are obviously doing it. There are areas that need to improve in terms of LVOT obstruction, so planning, and obviously I think CT is probably integral for this. Annulus sizing methods, particularly with the calcification. What is the best delivery approach? Is it transeptal? Is it transapical? And then going back to the discussion we had with TAVI back in the day, where we want to avoid those patients who are so frail and have so many comorbidities that they're really not going to improve regardless of what you do. So that cohort C population of patients. So the conclusion of the investigators is obviously this is feasible in patients with severe mitral valve disease due to MAC. It may be an option in those who are carefully selected. There is, however, an important learning curve, as we saw, with significant mortality in early experience that does improve. Certainly concerns with LVOT obstruction, and we need to further clarify what's the best way to do the procedure and best size the valve for this procedure. So I'm going to finish by talking about transcatheter mitral valve replacement, and Nick showed you multiple companies that are out there right now. I'm not going to review those in all detail. That would probably take an hour. But it's important to understand that this is probably going to be the future. There are numerous devices in development, but as you know, the technology has to fit around the mitral valve anatomy, which is quite complex. What are the design goals, obviously, for a mitral valve replacement? We want to completely eliminate MR, but yet preserve the subvalvular apparatus, lessons learned from our surgical colleagues, minimize LVOT obstruction, minimize leak, address the patient sizes. We want to prevent valve thrombosis. This is becoming something we're becoming more keenly aware in terms of aortic. We want the procedure to be simple and hopefully eventually target a transfemoral venous approach. And then we need to understand where the limitations are going to be. One valve won't fit every patient, and so that's going to be something to take into consideration. This has been an area of extensive funding over the past year and really been a hot topic. If you look just at the funding for transcatheter mitral valve in 2015 alone, over $2 billion. And the estimated target population is going to be between 2 to 4 million cases. And that includes people who are going to need either repair or replacement. And this, just to give you an idea, Medtronic's purchased 12, Boston Scientific's purchased M-Valve, Abbott has purchased Tendyne and has an interest, I believe, in Safea, and Edwards has Fortis and has now purchased CardioQ. So there's a lot of movement in this field for the 108 cases that are in humans. There's a lot of promise in this industry, however. So if we look a little bit about the different programs here, there are transcatheter mitral valve technologies that have active clinical programs that are under protocol. There's a study underway in the US with Abbott Tendyne. Edwards CardioQ is working on a study, Medtronic 12 as well, and Neovasc, which is based out of Vancouver. If we look at first-in-human studies within the last 24 months, we have 5, Safea, M-Valve, Caisson, HiLife, and Valtech. And this is actually only 20 companies, and Nick showed you several more. So there's many other companies that are working on something for this field. Just to summarize the big 5 that we have, if we look at the big 5 that have had probably the most implants so far, Abbott Tendyne, Edwards CardioQ, or Cardiac, Edwards Fortis, Medtronic 12, and Neovasc. I just want to draw your attention to the size of these things. So we always got a little bit sheepish when we put an 18 French in the groin. These are 32 French, 33 French. The Edwards Fortis was 42 French. Now these are obviously transapical, but these are not small devices, and they will have a significant impact likely on the ventricle. 35 French for the Medtronic 12 and 32 French for the Neovasc. So these are big devices, and as you can imagine, the majority of these are going transapical. If we look at what the human experience is, and these are slides that I got from EuroPCR, human experience with Abbott Tendyne, 31 cases, first implant in October 2014, 12 for Cardiac, 23 for Fortis, 15 for Medtronic 12, and 15 for Norvasc, I just want to draw your attention to the 30-day mortality. This is one of the things that's plagued this technology so far, and it'll be interesting to see how it comes out. 30-day mortality, 1 out of 23 for Abbott, which is clearly the best for Tendyne. 5 out of 11 for cardiac, 5 out of 13 for Edwards Fortis, 2 out of 15 for Medtronic 12, and 3 out of 11 for Neovasc. Just a sobering point for you, there's a lot of enthusiasm for this technology, but I think we need to accept the fact that we're not there yet. We're not ready for prime time with this technology. It's very exciting, but still a long way to go, I would say. So I think probably the future for mitral valve disease, percutaneously anyway, is transcatheter mitral valve replacement. But I think we're not quite there yet, and it's going to take a little while before we actually get there. So just to summarize for you, I hope I've been able to show you there's a high prevalence of moderate to severe mitral valve disease in our aging population, the predominance of which is mitral regurgitation. For now, the most clinical experience is with the edge-to-edge repair with MitraClip. However, there's some novel annuloplasty devices that are CE marked and are showing some promise. Most likely, the ultimate future is in transcatheter mitral valve replacement, but the road ahead is likely to be more challenging than that we saw with TAVI. And then just to finish with this about the heart team, and we talked a lot about the heart team for TAVI, but the heart team for mitral valve disease is absolutely essential and just as important. The only person who's not on here, I think, is the heart failure specialist, particularly when we're talking about functional mitral regurgitation. And they have an important role to play with optimizing medical therapy prior to doing any kind of intervention. And I'll just leave you with this from Helen Keller: alone we can do so little, but together we can do so much. So thank you.